often. But now let's talk about the abdomen. Click. So the opinions and assertions contained herein are the private views of me and are not to be construed as official or as reflecting the views of the departments of the Army, the Air Force, the Navy, or the Department of Defense, and I have no conflict of interest disclosures. Click. So we're going to talk about the abdomen, and there's a lot going on with the abdomen. So we're going to go over the anatomy because there's a lot of different system and bits that we have going on there. We want to talk about the health history. So this is pertaining to when we are getting our history from the patient. And we want to delve a little deeper into some of the questions that we want to ask females when we're talking about the abdomen. We're going to go over the red flag symptoms that could possibly signify a life-threatening condition. We're going to talk about our medical examination of the abdomen. We're going to get into some pelvic fractures. We're going to talk about trauma. We're going to talk about some of our other tools to help us, which is going to be radiology, ultrasound, and then utilizing the FAST exam. Click. So the abdomen is home to many vital organs. Some of them are not necessarily vital, but we got stomach, liver, small and large intestine, pancreas, gallbladder, spleen, appendix, bladder, kidneys. So when we're talking about the abdomen, we typically divide it into 4 quadrants: the epigastric area and the retroperitoneal area. So in that retroperitoneal area is where we're going to have our kidneys and our pancreas, and everything else is also in the front. But anatomically speaking, our lungs dip down into our abdomen. Now, that typically is not part of our abdominal exam, but we have to think about what's behind those organs. When you take a deep breath, those lung lobes are absolutely down in the abdomen with the diaphragm. Click. So the abdomen also has important muscles and bones. We could not ambulate. We could not achieve any type of posture without the muscles and bones that are back there. So that is part of the abdominal exam. And we have nearly the entire digestive tract is located in our abdomen. We have the liver, kidneys, and the spleen that's filtering our blood, eliminating wastes. And of course, our pancreas, which is absolutely fantastic at regulating our blood sugar. And it produces those lovely enzymes in order to aid in the breakdown of foods. Click. So when we start talking about a history and taking history, obviously we know we're all going to ask what the chief complaint is. Why is this patient here? Why did they come to see us today? So we always start with that sample history. We want to know the signs and symptoms. We want to know what is going on with that patient. Let them talk. We always want to make sure that we're doing open-ended questions. We want to know if they have any allergies to drugs or medications. We want to know what medications they're taking, because when we know what medications, that can help guide us down a path of thought that could help us with diagnosing them. We want to know our past pertinent medical history. If they've had abdominal issues before, we would like to know that. If they've had abdominal surgeries before, we'd like to know that. Now, last oral intake is one that I think kind of gets lost when we're looking at like musculoskeletal type complaints. But when we're talking about the abdomen, because we have basically the entire digestive system there, we need to know what their last oral intake. And thinking about that last oral intake, think about the location you were at and where the patient might have been. Is this in a deployed setting? Has this patient been eating possibly undercooked meat that may have some sort of parasites in there? And that could be that complaint. We also want to know, are they doing any types of special diets? Are they taking any supplements? There's a lot that can happen with our digestive system. And of course, events leading up to this injury. We want to know, did they just wake up with it? Did it come on acutely, or was it insidious? Did it start off as a little pain, generally over the course of a day, days, or even weeks? Did it then get to pain? Has it gotten better since it started? Has it gotten worse since it started, or has it stayed the same? And of course, we want to OPQRST every bit of pain that that patient is having, starting with onset. What were they doing when it happened? I think it gets confused sometimes, onset and time. So you can ask those both. What were you doing when it happened, and when did it happen? It can be asked at the same time. P, that palliativeness. That's what makes it feel better, what makes it feel worse. When we have somebody that say might be having a kidney stone, standing up and walking around, that can make them feel better. Again, that can that can guide us down that path to finding that diagnosis. Our quality. There's a lot of different words that can describe somebody's pain, and we want to make sure that we are letting the patient use those words. It's not a good idea to try to guide them down a path to certain words. So when you're talking about the quality of the pain, you don't want to say, is it dull or is it sharp? Because then you've only given them two different choices, and they're going to pick one of those when they might be properly describing it as burning or tearing. Now, radiation, we want to know, does this pain move up? Does it move down? Does it move left? Does it move right? Does it move forward? Does it move back? Because that can all give us indications. Are other systems having these same issues? Or is it just pinpointed in one spot? And of course, time, when it started, which can be asked with the onset question. So for our following slides, they're going to pertain to the pertinent questions that will assist with a proper history taking and diagnosis of the patient. Our questions should always be open-ended. We want that patient to tell us their story. Now, there is times where we need that patient to give specific yes or no answers. So it needs to be a balanced mixture of both of those. And of course, as we talked about the travel, dietary changes, lifestyle changes, trauma, we want to know as much history as we can. Click. So when we're thinking about our gastrointestinal disorders, we want to know if that patient has been having indigestion, anorexia. Do they have nausea, vomiting, or hematemesis, so blood in their vomit? Abdominal pain, obviously we always want to know about pain. Now, do they have dysphagia and odontophagia, which of course are nice big $10 doctor words. One of them is difficulty swallowing, the other one is painful swallowing. It is okay to use plain language. Do we have a change in bowel function? So this is a really important question. We don't ask necessarily, are you having a change in your bowel function? We want to start asking what's normal for them first. If you ask, are you having normal bowel movements, that patient's most likely going to say yes, but is what they think is normal actually normal? Does this person have 2 or 3 loose stools a day and has been having that for years, and that's what they think is normal? Does this person typically only have 1 bowel movement every 4 days and it's unpleasant for them when they pass that? So we want to delve into those questions. The frequency of a bowel movement. We want to know if it's difficult for that patient. Is it accompanied by pain? Those are all questions that can help lead us to something. And of course, with that, constipation or diarrhea. And again, we could have patients that have long-term constipation problems, but they believe that that is normal because we don't really talk to our friends about frequency and consistency of our bowel movements. And of course, jaundice. If there's something going on with the liver and your patient is Homer Simpson yellow, that's a pretty darn good indication there's something wrong there. But normally we're first going to see that jaundice when we're looking at the sclera, we're looking at the whites of the eyes. You see a little bit of yellow there, start thinking about that liver. Click. So going into our urinary and our renal disorders. So suprapubic pain, pain just above that bone right there, could be consistent with some sort of bladder infection. And along with that, we could have dysuria. We can have an urgency or frequency disorder with that, which also those can be tied to different types of sexually transmitted infections. So with hesitancy and decreased stream in males, that can be associated with an enlarged prostate, which could be prostate cancer. So if you are trained, that might be something where you're going to need to do a digital rectal exam to examine that prostate. If we have polyuria or nocturia, so we're having an enormous amount of urine frequency and we're having nighttime emissions, that can be a big problem. And when we're thinking about something like nocturia, or when we're having some of the dysuria, if we have somebody that's losing bladder control, that could be significant of some sort of nerve damage, especially when you have bladder control loss, abdominal issues, along with back pain, because the nerves from the spine innervate that area. So we need to know what's going on there. And hematuria, obviously we should never have blood in our urine. That's an important question. And that goes along with sometimes our travel, because there are certain infections and parasites that can cause that blood in the urine. So kidney or flank pain. So that, of course, we want to make sure that we're checking that out, because on that flank pain, that could be somebody's complaint of lower back pain. It could be kidney pain. We need to be able to differentiate that. And of course, urinal colic. Click. So when we're taking the health and the chief complaint history of a female of childbearing age, we always want to make sure we ask these following questions. We want to know the number of pregnancies and the number of living children that they have. We want to know if for those children, were they delivered naturally or were they delivered cesarean section? We want to know if when they were pregnant, if they were ever told that they had pregnancy problems or if they ever had concerns with the pregnancy. We want to know the date of the last menstrual cycle and if they are having any abnormalities with their menses. Just like the bowel movement, when you ask somebody, are you having normal menstrual cycles? What is normal for them may not actually be normal. And also thinking about their medications, when we have different birth control medications that can have quite an effect on frequency of menstrual cycles. Just like with bowel movements, we want to get into the weeds a little bit and try to get as much information as we can. And of course, we want to ask, is that patient pregnant? Now, any female of childbearing age, it's possible that they are pregnant. Before we do something like, say, radiology to look at the abdomen, we of course want to perform a pregnancy test because females can be pregnant and not know they're pregnant yet. And we want to make sure that we are not going to do anything that will be adverse to that fetus. Click. So here are our red flag symptoms. So unexplained weight loss. Now we all need to lose a little bit, it's quarantine, I've been eating way too much and exercising not enough. But when we have unexplained weight loss, so there's somebody that is consuming the same amount of calories, but they can't keep weight on, there's so many different things that could be from, let's say they're heavily infested with parasites, or they suddenly have some sort of genetic disorder where their large intestine isn't able to take nutrients and calories out of that food again. Organomegaly, so this is where we have enlarged organs. So you could have a patient that has mono. That's going to cause an enlarged spleen. We have to be very concerned about that enlarged spleen because what if they go play some rugby? They get hit, that could cause a ruptured spleen. So we need to make sure that, what size that is with palpation and percussion, or with percussion, not palpation, and also be concerned and let that patient know no contact sports for 2 weeks and give them a profile. Think about the size of the liver. If we have somebody that's having liver issues due to alcoholism, we can have that enlarged liver, and we can, with percussion, determine the size of that liver. Abdominal mass. So this is where, when we're palpating the abdomen, we find a mass. Now we want to know, what's the size of the mass? When we palpate that mass, does it cause patient pain? Is that mass mobile or is it non-mobile? And importantly, is it a pulsating mass? Now, as you all know from EMT school, if it is a pulsating mass, once you find it, you don't touch it again because that could be a AAA and we don't want that to pop. So hematochezia. So this is where you're having fresh blood in stool. Now, that's going to indicate more of sort of a lower GI bleed. Where on the other hand, if you're getting like a coffee ground type stool, that could be indicative of an upper GI bleed. So getting into those bowel movement and feces questions is important. Obviously, severe abdominal pain. If somebody is in severe abdominal pain, there's so many things to be going wrong, they need to get straight to an ER and a doctor. Bloody diarrhea, same thing. We should not have bleeding inside of our digestive system. It does not belong there. If we have a positive fecal occult blood, this is doing a smear on feces, activating a reagent that will be able to allow us to visualize if there is blood. Because if it's just a small bleeding leak, it's not going to show up on exam with the naked eye. So we need to use that test. And that small leak could turn into something more down the road. So we think about severe dehydration. It's bad. Somebody having severe dehydration, could be going into hypovolemic shock. They could absolutely be having organ damage from there. We need to make sure that we get these folks hydrated, we get them to a doctor as soon as possible. And of course, we always want to know about family history. So a family history of colon cancer means that you will have a higher risk for colon cancer. If we catch that early, that is something that we can help mitigate and extend that person's survival rate. And IBD, I am sure there are plenty of people that walk around that have mild cases of IBD that they think is just a normal amount of bowel movements a day or a lack thereof. So we want to ask those questions. Click. So, of course, the first step to the abdominal exam is we want to position the patient properly. We want to make sure that they are laying on their back and we have their knees bent at about a 90-degree angle, which relaxes the abdominal muscles. We need to explain what this exam is. You don't just lay down, pull their shirt up, and go for it. We want to make sure that the patient is comfortable. It's always a good idea to have a chaperone in the room and or offer a chaperone to the patient. We want to wash our hands, we want to don the gloves. Patients' arms should be at their side. If the arms are above their head or they're kind of behind the head, just relaxing like that, that can kind of stretch out those abdominal muscles and make it harder for you to do both light and deep palpation. We want it exposed as much as possible, but we have to think about the patient comforts in mind for that visual inspection because we do want full exposure going from just above the xiphoid process all the way down to the symphysis pubis so that we can visualize the entire abdomen. Click. So we want to, of course, just take a gander. We want to look for any scarring, bruising, lesions, if there's rashes or dilated veins. That dilated veins, if you have like a bunch of large dilated veins starting from the umbilicus outward, you get that Medusa head. That is a very bad sign, life-threatening condition. Then scars. Scars are important to pay attention and then ask the question about that. If you see scars in one in each quadrant of the abdomen, that could be that they had some sort of laparoscopic surgery. And if they had laparoscopic surgery, why did they have it? Was something removed? Did they have other scars from trauma? Did they get stabbed with a knife when they were younger? We want to know those because that could be a sign of something that is wrong with them. And for looking at the contour, obviously when we're looking just straight down at it, we can see that nice symmetry. But we then also want to look at it from the side. You want to squat down and look at it at eye level so that you can see if it's flat, if it's rounded, do you see any bulges? And that also allows you to see aortic pulsing when you're at that eye level. You'll see that abdomen sort of twitching up and down right in the center. And what's a good thing to do there is we can feel the patient's radial pulse and see, are we having things match up? There can be a slight delay, but we want to know, is that pulse the same for both? And when we are looking straight down at the abdomen, that's where we can actually sometimes see peristalsis. We can see the small intestine and large intestine squeezing and moving that chine through the digestive system. And that's a normal thing to see. We shouldn't see a large amount of that. That could be significant of some other condition. And of course, if they're having any complaints of abdominal pain, have them point to the area or areas of pain. Now, with the abdomen, sometimes they can pinpoint exactly where they're having the pain, or it can be rather diffuse. They can say that there's generalized abdominal pain, but have them show you where those areas are. Click. So after we perform our visual inspection, we want to move on to auscultation because it provides us some important information about bowel motility. We want to listen to the abdomen before we do any percussion or palpation because those can alter that frequency of bowel sounds. We don't want to kind of move everything around before we have a good listen to it. So normal bowel sounds consist of clicks and gurgles, which can occur at a frequency of anywhere from 5 to 34 per minute. So that's a pretty huge range for how often you are going to hear these sounds. We want to listen to all 4 quadrants and the epigastric area and right in the center of the abdomen because we want to listen to where all the movement of peristalsis can occur, as well as the abdominal artery for listening for bruits. Now, if you have an absence of bowel sounds, that can indicate a serious abdominal disorder, something like an insusception or a blockage. That is something that needs surgical intervention as soon as possible. Click. So for percussion, percussion can give us some good information. So what we do is it helps us assess the amount and distribution of gas in the abdomen. Now, all of us have gas in our abdomen. That's a natural byproduct of the breakdown of the foods and fluids that we eat. So what we want to do is we want to percuss the abdomen lightly in all 4 quadrants to assess the distribution of tympany and dullness. Now, if you see in this image, we want to start in the right upper quadrant, and we're going to hit a few areas. We go to the left upper quadrant, hit a few areas. We go to the lower left quadrant, hit a few areas, and then we get to the lower right quadrant and hit a few areas. So for the tympani, this is where we have that reverberation of sound from a nice hollow gas-filled space. So it'll have that higher sound, that tympani over gas-filled spaces. And you'll have a lot of that in the abdomen because there's a lot of gas in that GI tract. We also want to assess for where the dullness is, and that's going to be scattered areas due to fluid and feces. So if you can imagine, we think about how the food moves through the body. It is somebody that is complaining of left-sided abdominal pain, and you percuss the left side, and it's dull on the left side, but you have tympani on the right side. That could be that they have a large amount of feces in that descending colon, giving us some great information. Click. So once we've done our percussion, we move on to palpation. So we want to palpate the abdomen with a light, gentle, and dipping motion. Before we do this, we want to remember where that patient is having pain, because we don't want to poke at the pain first. We want to examine the other areas first to see, can we elicit pain from those areas, or if we press down in an area that has no pain and the area that has pain increases, that will tell us more information. We want to move smoothly, feel all 4 quadrants, and we want to note any superficial organs, any masses, any areas of tenderness or increased resistance. That increased resistance will be that patient tightening the abdominal muscles, because if you're causing them pain, they're going to tense. And if it's really bad, they might even do what's called guarding, where their hands will come up or they'll try to move your hand away. Because as humans, we don't like pain. We will do whatever we can to stop that pain. That is something that is indicative of something going on bad in the abdomen. Once we do our light palpation, then we get in deep. We want to go pretty darn deep to feel all 4 quadrants. And same thing, identifying masses. We want to note the location, size, shape, consistency, if there's tenderness, if there's pulsations, and mobility. Once again, if you feel pulsations, we don't touch that area again. Doctor and surgeon. Next slide. So we're talking about rebound tenderness. So appendicitis is something that is pretty common that we'll see in emergency rooms and even on the ambulance. So one of the things that helps us determine whether or not this patient has appendicitis, one, ask them if they have their appendix. I have had patients that think they have appendicitis, but they actually had their appendix removed when they were younger. But we want to palpate for rebound tenderness in the right lower quadrant. So if you look at the image, we have our umbilicus, and then we have the anterior superior iliac spine. Roughly 1/3 of the way from the anterior iliac spine to the umbilicus is McBurney's point. How to assess for that rebound tenderness is that we want to push down to a deep palpation level right on McBurney's point. Now, in some cases with appendicitis, this can actually relieve that patient's pain. So that's an important thing to note. And when we're going to do rebound, we want to quickly remove our finger from that area so that that abdomen springs back up. And if that causes a great increase of pain on that patient, that is something we need to think of as appendicitis. But we don't just want to do McBurney's point, we want to do all 4 quadrants, because if somebody's having something like peritonitis, they're going to have that rebound tenderness possibly in all 4 quadrants or more than 1 quadrant, which will take us down a different road than thinking about appendicitis. Click. Now, we tend to think the abdomen is just the bits in the front, and that's how we position the patient. They're laying on their back, and we just kind of poke everything at the front. But we got to remember, we have flanks, and we have that retroperitoneal area. So after we've done the abdominal exam, we want to have that patient sit up, and we want to assess for tenderness at the flanks and at the costrovertebral angle. Now, you obviously still start. We start with some light palpation, then we move on to deep palpation. But in order to elicit tenderness from those kidneys, you might need to use some fist percussion. As you see in the image, we are placing the palm of our hand on the lower part of where the kidney is in the retroperitoneal space, and we are using the ulnar side of our other hand to strike it with a fist. This you're not trying to really slam this into a patient, but you do need to strike with enough force that it should cause a perceptible jar in that patient or a thud. Now, one of the things that this can help us identify is going to be something like nephrolithiasis, because that vibration from that thud of checking that CVA tenderness will cause that to get jostled and increase the pain. This patient is going to let you know very quickly that what you did, they did not like. Click. So that's pretty much looking at the medical side of the abdomen, sort of the non-traumatic complaints and things we can look for. Now, when we move into trauma-related abdominal exams, it doesn't mean that you are going to ignore the exams that you would do if this was a medical instead of a trauma patient. You are going to do both. But before we do anything when we're talking about a trauma patient is that we need to make sure that all major bleeding has been controlled. Abdominal trauma can be what's called a distracting injury. Eviscerations is something that your mind just wants to go and help that, and you could miss insidious bleeding from an artery. So make sure that that patient has all the bleeding is controlled. Make sure that that patient has their airway opened and it's maintained, and they are either self or being mechanically ventilated before you focus on the abdominal trauma. We want to make sure that we keep our patients alive long enough to treat the abdominal trauma. Click. So with any type of blunt or blast injuries, we have to always be thinking about pelvic fractures. You can have an open book fracture, lateral compression, vertical shear. None of those look pleasant at all. And roughly 26% of service members who died in OEF and OIF had pelvic fractures. So a lot of blast and blunt trauma injuries. That's 1/4 of the deaths. So we can imagine, and we should be always thinking that anybody with blast or blunt trauma in the abdominal area needs to have a pelvic exam and needs to always be thinking that is a pelvic fracture. So our pelvis is this bowl that holds our organs up so they don't just kind of spill all the way down. And when that is damaged, those sharp bones could be cutting into organs, and you can hold a lot of blood in that abdomen. Roughly about 2 liters of blood can bleed out into there. And bleeding pelvic fractures with a hemodynamic instability have up to a 40% mortality. We need to make sure that we stop the bleed internally by binding the pelvis. Click. So when we are going to examine the pelvis, obviously pelvic pain, if somebody is saying my hips really hurt, that's an indication they might have a fracture. If we see laceration or bruising at any of the bony prominences of the pelvic rim, a deformed or unstable pelvis, when we are looking at that person's abdomen and you see one iliac crest appears to be 4 inches higher than the other iliac crest, that is a pretty good indication that we have a pelvic fracture. When you have enough clinical indications for a pelvic fracture, you just bind it. We don't need to kind of go further to confirm. So also look for unequal leg length. That's something like the shear fracture, where you actually have one leg lower than the other because the hip, which of course is attached to the femur, is actually up higher. Want to look at if there's any scrotal, perineal, or perianal bruising. Is there any blood at the urethral meatus? As we said earlier, there should never be any blood in the urine. That is not something that we need. Massive hematuria. Yeah, if they are literally just peeing blood, that is a sign that there is some severe damage in that lower abdomen and the pelvis. If we find blood in the rectum or the vagina, you got to remember your trauma assessments. We do have to examine that rectum. And if there is bleeding, we have to assume that there is internal bleeding, and we need to take care of that as fast as we can. And neurological deficits. That blunt or blast traumas can absolutely knock out nerves, and if it can knock out a nerve, then it probably was enough that it knocked out the bone. Click. Now for our pelvic binders. Now I know when I went through EMT school a long time ago, we were taught to use a sheet because there weren't that many commercially available pelvic binders, and there is nothing wrong with using a sheet if that's all you have. Another good thing that you can use, patient's blouse. When you're in a setting where you don't have these things available, you take the blouse down and you can tie those sleeves together as an improvised pelvic binder. Now, these 3 commercially available pelvic binders are the pelvic binder, the T-pod, and the SAM pelvic sling 2. I've only worked with 2 out of these 3. So I've worked with the T-Pod and I've worked with the SAM pelvic sling 2. I found the SAM pelvic sling 2 to be easier to use, and it had the added benefit of a pressure release that lets you know when you have applied enough tension on the pelvic binder to put the pelvis back together. The T-Pod, it does work, absolutely. What I found with the T-Pod is, as you see, there is a bunch of lines going through a set of pulley system, and that's how it pulls it together, and that can absolutely get caught, or it could get twisted on itself or knotted, especially when we're talking field conditions. Now, I don't carry a SAM pelvic sling in my ruck. What I carry, of course, is the SAM junctional tourniquet, because the SAM junctional tourniquet doubles as a pelvic sling. So whenever you can, try to get equipment that can do more than one thing so that you're not doubling up on your weight. Next slide. So we have to place these pelvic binders at the level of the greater trochanters. Obviously, don't place it on the iliac wings. If we looked at that open book fracture, that shear fracture, can you imagine the damage and pain would be caused if you put that pelvic binder on the iliac wings? So in order to find our correct placement, one, as you can see, right at the level of the pubic symphysis is the greater trochanters. This is where you have to palpate that patient and find where the greater trochanter is. Slide that pelvic binder underneath them and make sure that it's even over those greater trochanters. This is something that needs to be practiced. This is where we need to practice on each other, because we have a lot of different sizes and shapes, and leg length and width of the pelvis, and not everyone is going to be exactly the same. So we need to practice so we get it on that greater trochanter every single time, so we're not causing increased pain or increased trauma to that area. Click. We also have to think, if we have pelvic fracture, and obviously the pelvis is connected to the femur, we could have some discrepancies about leg length, as we talked about. And if those legs move, if we have any external rotation of those lower extremities, that's going to cause some pain, and it could actually increase the dislocation of the pelvic fragments. So external rotation can be prevented or reduced by securing the knees or feet together, improving the effect achieved by a pelvic binder. So as you see in this picture, we have this airman that has just below his knees and at his ankles, they've been bound together using cravats. That works absolutely fine. Personally, I would use my cravats for something else, and what I would use for this feller is I would just use some duct tape, and I would just duct tape his legs together, or medical tape. Both are going to be easily cut if we need to, and it's not using a piece of equipment that could be used for another patient. And of course, we do not want to log roll these patients, because that's going to put a lot of pressure on that pelvis, and that is going to cause increased pain and increased trauma. If at all possible, we want to use a scoop stretcher to move this patient from the ground or point of injury onto a litter. Click. So with blast injuries, we can have a lot of trauma to a bunch of parts of the body, but since we're focusing on the abdomen, we want to talk about the different blast waves. So our primary blast wave, this is the overpressure wave that can damage hollow organs in the body, as well as our eardrums. That secondary blast is the shrapnel that can be propelled at great speed and penetrate the abdomen and other parts in the body. And unfortunately, the bad guys are adding things to their bombs specifically for that, adding nails, adding ball bearings, adding just pieces of rocks, because that causes an enormous amount of trauma. And then we have our tertiary blast. So this is what can hurl that patient backwards and cause another object to cause them blunt force or trauma. So just like in the movies, the explosion goes off, they're thrown back, they land on their back, they land on their side, they can be thrown against a wall. That's going to cause damages. And then we also can get burns with that thermal injury from the quaternary blast. Click. So the primary blast is going to damage those hollow organs, because that overpressure wave is going to cause expansion, contraction of gases. So hollow organs such as the gallbladder, the stomach, small intestine, and the bladder can all be affected, and they could rupture, and they could leak toxic chemicals that are supposed to be used for digestion into the abdomen. And when we are thinking about primary blast damaging the hollow organs, remember the lungs are down far enough to be part of that abdomen. Those could be damaged too if we have damage to the abdomen. One of the ways we can kind of assess whether or not it's likely that there is going to be damage to hollow organs, to include the abdomen and the lungs, is the eardrums. So if that patient has ruptured tympanic membranes, which can be characterized by some blood coming out of the ear, reduced or absent hearing, that could be a sign that there are going to be internal damage that we need to mitigate as soon as possible. Also, when we're thinking about any type of rupture of the internal organs, specifically the digestive system, is we have to think about that secondary infection down the road. Now, somebody who has torn open part of their large intestine is going to get an infection eventually, but not immediately. So it's not a life-threatening concern right now, but it is going to be a life-threatening concern later. So if at all possible, we want to make sure that we get some antibiotics on board as soon as possible. If antibiotics are delayed, it reduces long-term mortality. Click. So for our secondary blast, so this is where it's damaging the solid organs. So this is going to be our shrapnel. This is going to be also when we're being tossed. This is like liver, the spleen, pancreas, kidneys, ovaries. They may significantly bleed due to tears or lacerations. When we think of the liver, think of kidneys, think of your spleen. Those are designed to take all of your blood through them constantly throughout the day. The kidneys are filtering out waste products, liver filtering out waste products, and so is the spleen. So when you have any of those that are bleeding, there is an enormous amount of blood that can be lost from those areas. Abdominal bleeding is a life-threatening condition. We don't have tourniquets for the abdomen readily available to us. You cannot put a combat application tourniquet or a soft tourniquet on that. Now, I know some of my experienced folks out there do have ways of mitigating this, but for the most part, we do not have anything that we can do for these significant abdominal traumas except recognize the signs and symptoms that this is life-threatening, so that we can get these patients to a Roll 2 facility as soon as possible and they are triaged appropriately. Click. So for penetrating abdominal wounds, so all penetrating abdominal wounds require an occlusive dressing. And of course, we need to stabilize that penetrating object. We don't pull out the stuff because that can make it bleed even more. Now, I know it is hard to stabilize some objects, but we need to do whatever we can to stabilize that. And it's important that we use an occlusive dressing. Whenever we're doing anything with the abdomen, we need to keep that abdomen sealed as much as possible, because our organs inside our abdomen, they like being moist. When they are exposed to the dryness of the air, we start losing some of the capillaries, they start drying out, and that can cause permanent irreversible damage to our digestive tract. So the occlusive dressing basically is not allowing air inside the abdomen and moisture out of the abdomen. Same for our open abdominal wounds. We have a large open abdominal wound. We want to cover it with a sterile, moist, occlusive, bulky dressing. So the reason we want to actually moisten this dressing is because if you put a bunch of dry Kerlix on there, that's going to absorb that water from the abdominal area and can actually cause damage to it. Also, a moist dressing is less likely to cause it to adhere to whatever abdominal organs are exposed. And of course, when we have an evisceration, we want to make every attempt to keep the intestines outside of the body moist with a sterile, occlusive, bulky dressing. We never want to try to force intestines back into the abdomen. Try to keep them as moist and sterile as possible. I think it's only about after 15 minutes of exposure to the air, we start having cellular death from an evisceration. Click. So both blunt and penetrating abdominal injuries have the potential to cause severe bleeding. Severe bleeding kills people. So if you are TC3, MP trained, initiate your field treatment protocols as tactically feasible as you can. Of course, on board, tranexamic acid, absolutely required. Fluid resuscitation. We do not want to jam a bunch of saline into somebody that is bleeding. Give them whole blood if you have that available. As we talked about, doing antibiotics as soon as possible. If they can swallow, give them moxifloxacin from their combat pill pack. If they are unable to swallow, we're going to give them ertapenem. Always pelvic bind folks that have had penetrating abdominal or blast trauma where we think that there is a pelvic injury. And of course, we want to give these folks pain relief, whether it is mild to moderate pain, moderate to severe pain. We have options such as the combat pill pack, ketamine, and fentanyl, depending on that patient's stability and if they're hemodynamically and respiratory stable. Click. So even in third world countries, radiology is available. X-rays have been around for many, many years. And even though there may not be a radiologist at that small austere clinic, you can still get a radiograph and we can look at it and it can tell us a few things. We can sometimes detect kidney stones. We can detect an obstruction, a perforation, an abdominal mass, and especially metal objects. Metal objects just glow on an X-ray. It's important with that when we're thinking about our pediatric patients because kids love to swallow coins, right? So we take an abdominal X-ray, we can see where that coin is. Usually not that big of a deal if a kid swallows a coin. But what if you have that swallowed coin with pain? Those two combined means that maybe that coin is actually causing obstruction, or maybe it's not a coin. Maybe it's one of those button batteries, which can cause severe trauma to the abdomen. It can also show us the distribution of fecal matter and gases within the GI tract. So typically, the more solid something is on an X-ray, like bones, the lighter in color it is, where gases or empty spaces are darker. And as you can see with this particular image, there is a lot of gas in that large intestine. Click. So according to the Joint Trauma System Clinical Practice Guidelines regarding imaging, so medical imaging absolutely plays a critical role in the rapid diagnosis, effective triage, and the management of complex polytrauma patients. High quality medical imaging can be accomplished successfully in a deployed or wartime setting. So if some of our theater clinics, our theater hospitals are absolutely fantastic. We have the latest technology. Sometimes we do not. But one of the things that we are doing now is a lot more ultrasound because I can carry that in my pocket. I cannot carry around a CT scanner in my pocket, nor do I even know how to read or interpret a CT scan. But utilizing both CT scans and ultrasounds, we can reduce the time from the patient being examined on the table to going into the surgery, which is incredibly important. The new 4N CFETP is now including the FAST exam, which will assist our providers and technicians with rapid scanning capabilities to quickly find potentially life-threatening internal bleeding. Click. So our ultrasound exam for the abdomen can provide a lot of insight into a patient's abdominal exam. So if you're working in a large trauma bay, you have probably seen ultrasounds being deployed for a FAST exam. They're usually on wheels. They're about the size of our standard EKG machine on wheels. This one's a nice little portable one. This one's not very big, and it can do a lot. And while hospital ultrasound machines are large and bulky, they are getting smaller and smaller, and they are such an important tool to give us instant access and visualization of those organs. Click. This is a fantastic little ultrasound. That thing is about the size of a cell phone, and we can use that in the field. Battery lasts a while. We can keep it in our pocket. So how it works is we have a transducer that actually gives off sound waves, and they are reflected back to that transducer head from organs and tissues. And it allows us to see what's inside of the body, and it basically takes that sound waves and transmits it to an image on the screen. The transducer produces sound waves from 1 to 18 megahertz. Now, when you are using that transducer, you need to, it is best to have some sort of conductive gel, because if there is a gap in between the ultrasound device and the skin, it's not going to be able to reflect those sound waves properly. So use the ultrasound gel if you have it. Hopefully you have it. Click. So these sound waves that are emitted from the ultrasound head, they are directed towards the body's tissues. The denser the object the ultrasound hits, the more the ultrasound bounces back. So high density tissues and spaces in the body are lighter, where our lower density tissue spaces within the body are darker. And that includes fluid. So fluid, it doesn't really reflect sound waves because of its properties. Sound waves just pass right through it, so it doesn't give us that bounce back compared to looking at the X-ray where the solid stuff is lighter and the non-solid stuff tends to be darker. But when we understand the different echogenicities of these tissues, it allows us to differentiate between bone, organs, fluids when we're performing that fast exam. But it is important to understand that there is a limitation of the ultrasound as it can't see behind bones. Once that bone has reflected the sound waves back, it can't get sound waves behind it to see those organs. Click. So the FAST exam, the focused abdominal sonographic assessment for trauma. Once again, the $10 doctor words. So our FAST exam has been validated only in hemodynamically unstable blunt trauma patients. It has become a standard tool in the trauma bay and emergency departments in most trauma patients. It is now considered an adjunct to the primary survey in advanced trauma life support guidelines in the 9th edition. It has also come into use for hemodynamically stable patients and penetrating trauma in the deployed setting where the CT scan is not readily available. And if the FAST exam is positive, it can provide quick information that can aid trauma surgeons in triaging patients, either to the operating room or getting them to further imaging at a different location. Click. So our FAST exam in combat trauma has a sensitivity of only 56%, but has a specificity of 98%, which is fantastic. Routine use of the FAST exam in trauma patients allows for consistent evaluation strategy while maintaining the skills of the provider. Now, how often we get to do a FAST exam obviously depends on where we're working and our skill level. But now that this is included in our CFETP, everyone should be able to get a lot more hands-on training this, both on training days, also working with this on the patients in an ER. Now, you got to remember that just because you have a negative FAST exam does not mean that you can rule out internal bleeding. A negative FAST exam, because again, that sensitivity is only 56%, we might want to get that over to some other imaging. But if we do have a positive FAST exam, we know that person needs to get over to an ER and a surgeon as soon as possible. And the availability, the portability of ultrasounds enable us medics to better perform our abdominal exams. There are even ultrasounds where you can just purchase the handle and it will plug into your Android or your Apple phone. They are amazingly portable. One of the limitations that I know that they're working on is the crystals inside of that ultrasound head are not the toughest. So getting banged around in a rucksack is not ideal for this equipment. But as technology advances, we should hopefully get much more rugged ultrasound heads. Click. So our FAST exam is designed to figure out whether or not we have free fluid in the chest, in the abdomen, also in the retroperitoneal space. Now, just like any skill, the more you do it, the better you get. And it is a perishable skill. So if you haven't done it for a while, you're not going to be that great. I have absolutely seen this done in less than 5 minutes in trauma resuscitative units, but these are also folks that are doing it probably 5 to 10 times a day. It'll probably take me about 20 minutes to do a FAST exam. It's been a while. Click. Well, actually, go back. So what we're seeing here in this image, so this is a right side flank that we are looking at. So we see the kidney, we see the liver, we also see the lobe of the lung. I know I keep talking, the lung is part of our abdomen. And what you have in these jet black, this anechoic space, that's free fluid. Now, can you 100% say it's blood? No. Most likely it is blood, especially in a penetrating abdominal trauma. So this is what the things that our FAST exam is looking for, is that blood in between liver, lung, diaphragm. Click. We also can look at the heart. So we can take a look at our cardiac view, and that's going to let us see, do we have any type of fluid inside the pericardium? Can we see all the heart chambers? tell us a lot about that going on. For that right upper quadrant, which is the picture you saw in the last one, that's where we're looking at fluid in Morrison's pouch. We can see the tip of the liver and the lower right thorax, and you can see that lung lobe. If you don't have that lung lobe moving when you're looking at the right upper quadrant, that could be significant of a pneumothorax or a hemothorax. On the left upper quadrant, we're looking for that subphrenic space, the splenorenal recess. $10 doctor words, love them. We can see the spleen tip and of course the lower left thorax. Again, we can see that lobe tip. Take a look, make sure that that is moving and it's not free fluid in there. And we also want to look at the bladder because we can see blood or free fluid around that bladder, which is the rectovesical pouch in males or the rectouterine in females. Click. So in conclusion, summary, so the abdomen houses major organs responsible for digestion, blood filtering, hormone production. Make sure we are taking a good history to include sample and OPQRST for all the pain. We need to also ask clarifying questions that help us understand what's going on and make sure we are asking those questions for any female of childbearing age. Remember that examining the abdomen is a systematic process searching for abnormalities. Abdominal trauma can cause severe life-threatening injuries. We need to stop the bleed. And that we now have some improved technology that allows our medical technicians to utilize an ultrasound to help determine if there is internal bleeding and reduce the time from intake to surgery. This is how we save lives by getting gooder. Click. Click. Any questions? Okay, well, thank you all for attending the first of a series of lectures.